Johannes Kieding, I'm back. I want to share more about my passion for this kind of psychotherapy, ISTDP. This is going to be about some of the philosophy and outlook, some of the basic premises of the model itself. Overview. So it's really about going beyond symptom relief in this model. There's a real sense of the human potential, that people have the potential to really go beyond just symptom relief, but to actually take charge over their lives. Real victimization versus the victim mentality. Empathy and challenge, they're not mutually exclusive. The interpsychic focus, right? This is very important, at least for this model of therapy, is that we have an interpsychic focus, the idea of self-inflicted pain being different from other inflicted pain. Working at the patient's highest level of capacity, the idea that as an ISTDP therapist, I'm not neutral. I'm always respecting my client's autonomy, but I don't pretend to be neutral. And then the conscious therapeutic alliance, which is so important, so crucial to do this effectively. So the human potential, from an ISTDP perspective, people have the potential to overcome the adverse effects of trauma by working through emotional conflicts. This leads to moving away from a passive, reactive way of being, where we live our lives on autopilot and take charge over our lives. This comes from an unwavering belief in the capacity for freedom, for agency in our clients. And this really characterizes the effective ISTDP therapist, is that we have this unwavering belief, or maybe even faith, if you will, in this kind of potential. Now, there is real victimization. There are actual victims. Everyone can be victimized. If you go up to me on the street and punch me in the face, I'm a victim of your violence, of your assault. People that are raped, right? So there are victims, and it's very important to acknowledge that and honor that. But to be victimized and to take a victimized position, or to take a victimized mentality, or what I sometimes call the injured party position, they're not one and the same. So we can very much recognize and show empathy for, when there's severe other inflicted pain, like real victimization. Of course, to have empathy for that. But we are also, in this model, encouraging people to find their agency and to do their part in improving their lives. In other words, moving away from a focus on other inflicted pain to a focus of self-inflicted pain. That is the interpsychic focus. So the pain, the suffering that ISTDP can help with is the interpsychic pain. We cannot really help with other inflicted pain or circumstantial pain, the agony and pain that comes from loss, illness, and heartbreak, right? The realistic pain of life is something we all have to accept. But what we do in ISTDP is we help the client see that added layer of pain, the extra layer of pain that comes from how we deal, how we wheel and deal, how we respond to, how we process life, the demands of life, the events of life. And so that's the layer of pain that we can help clients with, not the fundamental pain of reality, right, that we all grow old and sick and die and lose people and so forth. So, for example, someone who gets anxious and passive whenever they're treated poorly, right? There are two types of pain here. Let's be very careful. Let's be meticulous and look at this. The first pain is that of being treated poorly, okay? Nobody likes to be treated poorly. And no matter how much therapy you have, That's not going to change. You're not going to like to be punched in the face or demeaned, okay? Unless you're of a certain bent, but let's not get into that. So that's the first layer of pain. And then the second layer comes from getting anxious and then going passive on account of being treated poorly. Now, if we can help our clients access a healthy anger about being treated poorly, that can resolve that second layer of pain. And so that instead of feeling anxious and becoming passive, and then perpetuating the cycle where we allow people to treat us poorly, if we can instead have access to that anger and take assertive action, then that second layer of pain is resolved. It doesn't mean that it's wonderful. Again, it's not wonderful to be treated poorly when it happens, but at least we're not adding additional unnecessary pain. So here's an example. A patient comes in and vents about other inflicted pain. You know, what so-and-so did to me, and so-and-so did to me, and this happened, and this was terrible, and this happened, and that was terrible. One way that we can deal with it. So here, right, we don't have an interpsychic focus in this scenario. That's what's missing. And so one way of intervening would be to say something to the effect of, I'm so sorry that this happened to you. If I had the powers to influence these events or the people that hurt you, I would. But honestly, I don't have that influence. And so how were you hoping that I could help you? Do you feel like you've handled these situations as well as can be expected or not? Or, I'm so sorry to hear about this. It sounds very painful. Now, therapy isn't that effective in dealing with other inflicted pain. You can say that. It's really to help with self-inflicted pain. Do you think that there's anything that you're doing in terms of how you process, deal, or respond to these difficulties that could use some work? So those are two examples of ways where as a therapist, you can try to gain a foothold into an interpsychic focus. So interpsychic focus essentially means an understanding and a focus on what the client is doing to create her own pain, her own suffering. It's the client's role in her own problems. That's the interpsychic focus. Without that, you have sessions that devolve into venting and just sort of giving advice and try this or try that. Now that can be helpful. It can be actually precisely what someone needs, but that in and of itself isn't likely to create deep and lasting psychological healing and change. Now, empathy and challenge. Now, empathy for both types of pain, the self-inflicted pain and the pain caused by life itself, is important. If we never address the self-inflicted portion, though, we can help the patient cheat herself out of a more empowered way of being in the world. We can perpetuate this injured party position, the victimized mentality. Again, real victimization and a victimized mentality are not one and the same thing. So we can and we should have empathy for other inflicted pain. But if we don't take it a step further and become more challenging and help the client see their own role in their own pain, if they do have one, if they don't have one, then all you do is another kind of therapy. But yeah, so we're not helping our clients grow. We're not helping them take charge over their lives and see their possibilities, their potential, their choices. We cheat our clients out of that unless we help them get an interpsychic focus, meaning help them see their own role in their own pain. So the take-home point here in terms of this concept is that empathy and accountability or challenge are not mutually exclusive. Empathy that does not include an invitation for the patient to look at his or her own role in her own problems is not a complete form of empathy. We're not helping them rise above a victimized mentality. So it's crucial that we help them see their own role in their own pain, and that we help them take charge over their lives by channeling emotions into adaptive action rather than staying stuck in their defenses, which is the self-inflicted pain. This is not victim blaming, okay? A simple invitation for the patient to look at what they might be doing to add more pain to their lives. That's what this is. We're not blaming actual victims. We have empathy when people are really victimized, tremendous empathy. If you don't feel that as a therapist, you've got more work to do. Now, again, we're also open to the possibility that perhaps a patient feels they really are handling everything as well as can be expected. There really is only other inflicted pain. They really do not have a role in their own problems, in which case we are left to do supportive work. We have to re-examine the therapeutic task at the very least. It could be that problem solving and support is really all that they want and need. The idea of working at our patient's highest level of capacity. So in ISTDP, we aim to work at their highest level of capacity. If we go above their capacity, that creates a misalliance, too much pressure and challenge. Below capacity can lead to stagnation and ineffective therapy, and that also can cause a misalliance. At the very least, the client simply is not going to get that much from our work. They might get something, but they will not get as much as they could be getting. They'll be getting a fraction out of what they could be getting. We're not neutral in ISTDP as therapists. We don't pretend to be neutral. We are certainly not engaging in a battle of wills. We don't try to drag people up a hill or do something against their will. But we can't pretend to be supportive of behavior that is clearly maladaptive. If a client is struggling with alcoholism and asks me to pour them a drink, I'm not going to do that, nor am I going to pretend that I'm in any way, shape, or form for it, right? So in this kind of therapy, we state our observations about what's going on. That on the one hand, there seems to be a battle within the client, let's say, a battle between the one side that wishes to perpetuate status quo, hang on to their symptoms, keep their resistances going, right? Avoid their feelings. And on the other hand, there's the healthy part that wishes for freedom, right? That wishes to be free, and that those two parts battle within the patient. That's the interpsychic, the core, the fundamental interpsychic conflict. There are others, but that's the fundamental one. And so we might say things like, so here's what's going on, right? Do you see how there's a battle within you between these two sides of you? And then we always just put them at choice. You know, which side are you on? The side that wants to hang on to these walls, these defenses, or on the side that wants to knock them down and have your feelings instead. So always, it's about the client's autonomy and their choice. We never try to make those choices for them, but we don't have to pretend that we are neutral. We can be honest that our preference is for them to lower their walls, but they certainly should not try to make these sort of changes in order to placate the therapist. That would be just another added layer of problems, another obstacle on the path that would have to be overcome. So we're always respecting our client's autonomy, but we don't pretend to be neutral. So this would be an example of not being neutral. The patient is there, they're evasive, they change the topic continuously. A pattern of self-sabotage has already been established. The client has been forthcoming and acknowledged just as much. Therapist, do you notice how you avoid being in real contact with me and here by being evasive and changing the focus as soon as we approach something emotionally charged? Now, it's a free country. You can certainly do that if you like, but could that be part of this pattern that we have identified of self-sabotage? The patient might say, I guess it could be. Therapist, and so what will happen to our work here together, your anxiety and depression and self-esteem issues, if you continue to be evasive and avoid your feelings by changing the focus? What will you get out of this for yourself if you continue to do that? This is a mini head-on collision. Do you want to spend the rest of the session like this? Because if you do, then this will end in failure. The premise here is that if we don't have access to your most intimate thoughts and intimate feelings, then this will be useless, or at least not as helpful as it could be. Okay, so that would be an example. We could also say, for me, it would be sad, I tried to help this young man or this young woman, but the wall was there and I failed. That would be sad for me. I don't like to fail, but I can live with it, right? It's the nature of my job that I can't succeed with everyone. This is all Davinu, by the way. This is Dr. Davinu who came up with these interventions. And then, but what would it be like for you, right? What would it be like for you if we say goodbye and in an atmosphere of defeat, right? Where this becomes one more relationship that is tossed on the garbage heap of other failed relationships where you didn't get out of them what you really needed and wanted, okay? So that kind of head-on collision demonstrates that we're not neutral. We care about our clients. We would like for them to do what they need to do in order to get better, but we can accept it. We will be okay if they choose not to. They certainly should not try to make those changes in order to please us, right? That's really a catastrophe. That would be a catastrophe. Huh? The Conscious Therapeutic Alliance. Nothing therapeutic, nothing healing occurs without the Conscious Therapeutic Alliance. It's absolutely crucial. And it consists of a consensus on what the problem is, what their goals are, what the therapeutic task involves, essentially the definition of treatment. And it was actually Dr. Patricia Coughlin who first spoke about this to me in a way that really resonated. She has that really clearly conceptualized in her writing and in her presentations. Also, it involves making sure that the client really feels that I'm in his or her corner. And it's so important. The client should feel heard, understood, respected. The client should feel that I'm interested in understanding their priorities. They should never feel like I'm pushing my own agenda onto them. This conscious alliance includes receiving explicit permission from the client to engage them in more challenging work, that is, overcome internal resistance to feelings that are pushed away or cut off, sealed off, dissociated from. This alliance consists of a collegial partnership where the therapist and the client that we're pulling in the same direction towards the same envisioned outcome and goal. So collaboration is the key. We are never, ever trying to drag our patients up a hill. Sensitivity to the client's cultural background, adopting the language and the meaning of the words that the client uses. We meet them where they are. So if the client uses the word stress, I'm going to use stress, not anxiety.